Hi there, I'm Joe Miller and we're at Cardiology Napa Valley 2017 and I'm with Erin Michos from Johns Hopkins, who have really been some of the world leaders in helping us detect early coronary calcification. And you just gave a wonderful presentation during the session on new approaches to risk scoring and finding and personalizing risk. Maybe you could give us just a little taste of what you think and where we're going towards the future out of your own group and your own experience.
Yeah, so in primary prevention, decisions about pharmacotherapy, notably statins, aspirins, really predicates on having the most accurate risk assessment. And certainly we recommend starting with everybody a global risk score, such as the American Heart Association, American College of Cardiology, pooled cohort equations. But in many cases, someone's risk is uncertain after you do this. And so we are really sort of favoring using coronary artery calcium as a way of risk stratifying somebody, so that individuals in a sort of a broad range of risks between 5 to 20% 10-year risk by the ACD calculator, maybe a group where their risk is uncertain enough that a coronary artery calcium score can help identify those who would most and least benefit from statins for primary prevention.
Well, Erin, one of the things that always comes up with patients a lot of times is this, and I think you hit on this well, and maybe you could summarize it for us, is that whole issue about radiation safety and coronary artery calcium scoring.
Yes, I really don't think it's an issue for the coronary calcium scoring, which is a non-contrast CT. It's about 1 millisieverts of radiation. So this is about the amount of a bilateral mammogram, and this is not a test that we get every year like women do with a mammogram. This is sort of one test that potentially, if someone's score is 0, and that the patient may want to defer statin therapy if their risk is acceptably low, and this could potentially spare them, potentially, decades of statin therapy if they decide to hold off on therapy. So it's a test you get one time. It's a very low amount of radiation. It's actually about the amount of radiation of someone's annual background radiation from just living in the US. So I think the radiation is really not an issue.
No, that's great. I think that helps overcome some of the concerns that we used to hear about. How about the other thing? Where are y'all with, and I know you probably can't make a recommendation to this, but patients come in with them, serial scans. What do you do with that? And do you tell them to stop? Do you tell them, well, thank you, this has not changed what I'm doing? Or, I mean, what are y'all's thoughts as some of the nation's leaders in this area?
Yeah, so again, I use coronary calcium scoring only in people whose risk is uncertain. So in general, most people with risk scores less than 5%, didn't need this scan, except, in special cases, if they have a family history and so forth. And people who have risk scores greater than 20%, really don't need the scan because their risk is so high, we would recommend treatment anyway. So people in that group, they may have done a scan on your own, or you may get the scan. If their score is 0, and you make the decision to delay or defer statin therapy, they may be indicated to get a repeat scan in 5 years or so if the risk is still uncertain about whether you're going to treat a statin or not. But if the score comes back elevated and you make the decision to treat, there's really no role in serial scans, because if anything, statins help remove the sort of the lipid, the modifiable plaque, and it doesn't do anything about the calcium that stays behind. If anything, statins can make plaques more dense and more stable, and the score can actually go up. So despite the fact the statins are reducing events, it does nothing to change the calcium score. So a calcium score is not a good way to follow somebody on therapy, so I don't recommend serial scans unless you're starting out with a 0 and you're considering a rescan if you're still uncertain about whether to start a statin or not.
Perfect. I think that helps so much with so many of the questions, because unfortunately patients do come in with those repeat scans. Now, and thank you for your time, by the way. I'd love for you to summarize some of that data you showed about the hypertension and calcium scores, because I thought it was really powerful. Sort of, I don't want to say it gives you the option to give lifestyle therapy a little more time, but I thought it was a really powerful point. And could you summarize that for us?
Yeah, so a lot of work from our group in Mesa and some of my colleagues at Hopkins have been, again, using coronary calcium scores to not only identify individuals who might benefit the most and least from lipid therapy, from statins. As I mentioned, people with 0 scores, their event rates are not 0, but their event rate is low enough that, even with a 30% reduction in statin therapy, their absolute rates are so low, you would have to treat like 500 people to prevent 1 event. Whereas if their calcium score was above 100, you'd only need to treat somewhere between 20 to 30 individuals to prevent 1 event. And the same thing could be modeled for other therapies like aspirin. So aspirin is a very narrow therapeutic window because of bleeding. And again, if someone's score is 0, their event rate is so low that even if you assume a 20% reduction with in events with aspirin therapy, you'd have to treat so many people to prevent 1 event. It actually the number needed to treat is far worse than the number needed to harm. Where if their score is greater than 100, it's actually favorable, where you could the number needed to treat is much less than the number needed to harm. And so we've modeled that in Mesa. And then one of my colleagues recently published a paper this year, modeling this again with blood pressure targets, such as the SPRINT data, about whether we should be treating individuals down to a blood pressure of 120. So in high-risk individuals who have risk scores greater than 15% or systolic blood pressure is greater than 160, coronary calcium scores are probably not going to make a difference in whether they would benefit. They would benefit from more aggressive blood pressure targets regardless. But for those that had blood pressures less than 160 and risk scores less than 15%, potentially coronary calcium scores might be able to guide you about whether we should be shooting for these aggressive targets. That if your score is 0, your event rate is low enough that you'd have to treat a lot of people to get blood pressures down to 120 to prevent 1 event, modeling on the SPRINT data. But if their calcium score was greater than 100, if it was elevated, you don't need to treat much fewer people to prevent 1 event. So potentially, coronary calcium can identify, it's a very good marker of someone's risk, so it can identify a high-risk individual that might benefit from a more aggressive pharmacotherapy, not only for lipids, but potentially for blood pressure and for aspirin. And at the same time, a score of 0 may make you favor really pushing lifestyle and maybe deferring pharmacotherapy in these individuals with low atherosclerosis burden and low predicted 10-year event rates.
No, that's fantastic, and I want to thank you for taking the time. I think you've really done a great job sort of clarifying what is a very cheap, very safe, very reproducible test. And y'all's group obviously has led the way with that. And thank you for taking the time to sit down with us and walk us general clinicians through all that.
Yes,
So
well,
we appreciate it.
Thank you for having me here.